An ankle course. So we are starting with the trauma sessions. Hopefully everyone had breakfast. And we have 3 sessions today: trauma, deformities, and miscellaneous, followed by workshop on bone model. So the chairpersons for this session, Dr. Bashir sir, please. Dr. Ritesh Pandey. Vinod Thakur sir. Yes, sir, please. Dr. Sukalyan, please. And the first talk is by Dr. Sandeep sir, and he'll be talking on pediatric foot and ankle fractures.
Will be, though the topic is foot and ankle, I will be mainly talking about ankle fractures. Foot fractures, with a very few exceptions, most of them are managed conservatively with immobilization in a cast. So ankle fractures, I'm going to talk about distal tibia fascial injuries, and then I'm going to talk about a specific special subcategory of fascial injuries, that is the transitional fractures. So first, distal tibia fascial fractures. So this is an injury. How do you classify this? How do you reduce this? And do you need to fix this? And if yes, then how do you fix it? So the classification of distal tibia fascial fractures, you can do this by the Salter-Harris classification, which is a generic classification for all fascial injuries. But the classification that is specifically used for distal tibia fascial injuries is the Takjan-Diaz classification. Now you can see that there are 4 categories of injuries in this classification, and there are 2 terminologies in each category. So it's a supination inversion, or it's a pronation eversion external rotation, or it's a supination plantar flexion, or supination external rotation. Now, out of this, the first terminology, that is, supination or pronation, that gives you the position of the foot when the deforming force was applied to the foot. And the second terminology, it tells you the direction of the deforming force. So in a supination inversion injury, the foot was in a position of supination, and then an inversion force was applied to it. Now, how do you identify what is the, what fracture are you dealing with? So that can be identified from this table, and I will just give you an example how to use this table. So take this injury. This is the X-ray which I put up initially. So here the displacement is in a posterolateral direction. The fibular fracture is high, and the metaphyseal beak is lateral. Therefore, if you go back to this table, this is a pronation eversion external rotation injury. Another example, here the displacement is medial, fibular fracture is low transverse, and there is no metaphyseal beak here. So again, you go back to the table, and this is a supination inversion injury. So this table can be used to identify in what category your fracture is fitting. Now, how do you treat this? So almost all the fractures are treated by closed reduction. Very few situations you require open reduction. So for closed reduction, what you necessarily need to do is you need to reverse the deforming force, and you need to immobilize in opposite direction. So here the Takjan classification comes in. From the Takjan classification, you know what is your deforming force, so you have to reverse that, and you have to immobilize in the opposite position. So for example, this is in a supination plantar flexion injury, you need to dorsiflex the ankle and then immobilize it in a position of pronation. Similarly, in a supination plantar flexion injury or pronation external rotation, eversion external rotation injury, you need to invert the foot, and then you need to immobilize in a position of supination. So that's how you do a closed reduction. There is one caveat over here, or one word of caution over here: beware of gap at the fracture site at the end of your reduction. This could mean an interposed periosteal fragment, and this has been described, and this is a predisposing factor for a fascial growth arrest. So if you see this gap, then it is an indication for going in, just opening it up, taking out that periosteal flap and closing that gap. Do you need to fix these fractures? So most of the type 1 fractures which are adequately reduced by Salter-Harris type 1 fractures which are adequately reduced by your closed reduction maneuver, you don't need to fix them. If at all you fix them, you can do this with K-wires. But in Salter-Harris type 2 fractures, where there is a large metaphyseal beak, you can make use of this beak to do the fixation. So you can fix these fractures with metaphyseal screws like this. By doing this type of fixation, you don't need to breach the physis. Your physis is completely safe. Same thing with the Salter-Harris type 3 or 4 injuries. Over here, you can put an epiphyseal screw, a transverse epiphyseal screw. Again, you don't need to breach the physis, and this is a very safe fixation. Now, many times, surgeons do the mistake of, underestimating a minimally displaced Salter Harris type 3 or 4 injuries. But remember that these injuries are fractures of necessity. They need to be fixed. The reason being, even a slight amount of malunion in these fractures will lead not only to articular incongruity, but it will lead to a step off at the level of the articular cartilage, and that can lead to a growth arrest. Example being this. So this medial malleolus fracture, because it was minimally displaced, it was, conserved. However, you can see that there is a step off at the level of the articular cartilage, and that has led to a growth arrest and deformity. Now coming to a second, subcategory of fascial injuries, that is the transitional fractures, and these are so called because they occur in the transitional age group between adolescence and skeletal maturity. We know that the tibial distal physis, it starts, fusing first in on the medial side, and then the fusion goes centrifugally towards the whole of the physis. And these fractures occur exactly in that transition period. That is, partially the physis is fused, but part of the physis is still open. So there are two types of transitional fractures, triplane and tilo. Triplane fractures, these are peculiar fractures in that on the AP view, they look like Salter Harris type 3 injuries, but on the lateral view, they look like Salter Harris type 2 injuries. But actually, if you go to see, these are, no, on the lateral view, they look like Salter Harris type 2. But actually, if you go to see, these are Salter Harris type 4 injuries. In order to identify the exact pattern of the injury, a CT scan is a must. And what the CT scan tells you is that at the level of the epiphysis, the fracture is generally in an anterior-posterior direction, but at the level of the metaphysis, the fracture is in a transverse direction. So this is a three-dimensional fractional configuration. The mechanism of injury is external rotation. So to reduce these fractures, again, you need to reverse your deforming force. How do you do that? You can insert a K-wire into the anterolateral fragment and then derotate or, internally rotate your leg in order to reduce the fracture, and the same K-wire can then be advanced, and this wire can then be used as a guide wire to put in your screw. The CT scan helps you, guides you to know the exact screw configuration. So in the epiphysis, you need to put generally an anterolateral to posteromedial screw. In the metaphysis, you need to put an anterior to posterior screw, something like this. Tilo fractures, again, these are again transitional fractures, and an anterolateral fragment which is attached to the distal anterior tibiofibular ligament, that is Avelsdorf. Again, these are external rotation injuries. You put in a K-wire into the fragment, internally rotate these, and then fix this. Something like this, okay? So this is about distal tibia fascial injuries. Be careful to identify the triplane fractures, and if you see a triplane fracture, you should do a CT scan, plan your fixation, and do it accordingly. Thank you.
Neglected injuries in the foot and ankle in the pediatric group. And as a principle, remember the child is not a small adult. The problems in trauma are also different in that non-unions are really very uncommon in the child, but malunions are much more common. And you need to be aware of problems related to the physis. That means growth plate and growth disturbances, growth plate injuries and growth plate disturbances. So we'll start with a case. This is an 11-year-old boy who fell from a height of 20 feet, was treated in a POP cast for 45 days, and he came with pain and swelling in the left ankle with a plantar flexion deformity of about 15 degrees and a jog-off movement. So that was the X-ray that we saw and the CT scan. So how would you deal with this? So this is a problem because this bump there is going to stop him from dorsiflexing the ankle, so he's going to be stuck in plantar flexion. So even though it's late, you still need to do something. So you need to go in, you really recreate the fracture because you can still see the fracture line there, and then reduce it, and then fix it with screws and threaded wires, and then we put a distractor on to keep the joint distracted so that otherwise the tendency would be for it to get compressed again and cause problems. So that is what we did. You can see the subsequent x-rays. Once we took out the frame, now you can see that the ankle is now within the joint and it's reasonably well held. Obviously, you need long-term follow-ups on these, and I think this Patient this is about a year down the line, he's still doing quite well. And then we, I think, took out the screws at about a year and a half. Here's another interesting case. This is, was a son of a neurologist and daughter of a neurologist, very obese, and this was her initial injury. And this, if you followed the classification, would be a classical supination inversion injury, okay? So what happens there is very often, this is like a type 1 injury, while here you have a type 4 kind of injury, okay? So this actually is a more vertical fracture line which tends to go across the physis to the metaphysis. So this was what was done, okay? Now, this was done by another senior surgeon in Patna, and I was out of town. The moment I got back, I got this desperate call from him, no, you need to do something, because this x-rays had been sent all around the world by this neurologist. And he said, no, you have to. And I was very scared at that stage because and she's really obese, this child, okay? So, okay, I said, okay, now, I know, but because she was about 10, I think she was 10, so I knew that there was not that much growth left. So the intra-articular problem was a bigger problem than the growth problem. So we went in, that was the kind of hematoma that he had. You can see the periosteum there was, we had to actually do an open reduction to get this back, and then we put a screw across. What's happening to this? It's too sensitive. So we put a screw across to reduce the articular area, and then this threaded wire which we put into the metaphyseal area, avoiding the physis. So we were able to avoid the physis with the fixation. Usually the fibular fracture in these fractures do not need fixation, because once you fix the medial side, it would tend to get into place. But of course, you need to make sure that is reduced. And then she went on and followed up, and she did well, and she actually got to skeletal maturity. Okay, unfortunately, I don't have her later x-rays and the follow-up, but we in fact removed the implants almost 3 or 4 years later, and she was doing quite well. Now here's another situation. This is the kind of problem that they develop if they've not been managed adequately. And this is a 10-year-old who ended up with, now here you know you've got a physeal arrest. You've got this entire medial side where the physis has arrested. You can see the fibula is still growing, and you have this deformity, and this is going to progress. So what you need to do here is you have to correct the deformity. Now you can do that in one of several ways. You can do it with an opening wedge osteotomy, or in this case we use the Ilizarov to do a gradual correction, but you also need to close the growth on the fibula. Okay, so you need to do an epiphysiodesis of the distal fibula. So here you can make it with multiple drills, you can put a screw across it, and also the lateral part of the tibia, because that is also still growing to cause this deformity. So you do that, that's what we did. We did an epiphysiodesis plus a sort of gradual distraction correction. You can see the hinges are very low so that you get the minimal translation. So there's a little bit of translation, but it gets aligned in terms of the mechanical axis. And this goes on to heal nicely. And you can see on the follow-up, it's got a decent ankle. And this is about a 1.5 year follow-up. It's still maintaining the correction. And because the growth in the fibula and the lateral physis has been also closed, it's maintaining the correction. And now he's almost 13, so hopefully it will not recur significantly. The last case, so that's the last follow-up we have, so it's still doing quite well. The last case is actually a post-Burns contracture, bilateral, and you can see that one of them has gone into extreme dorsiflexion so that the foot is actually aligned with the tibia, and the other one is in equinus. And here's where I think the distraction methods can come in useful. Obviously, you're going to need to release this tether here, and then you can put a distractor on. So we use the Jess fixator, one going the reverse way for the correction and the other the standard way for the correction. And you can see how gradually with the distraction, the skin also kind of tends to form over that area. We didn't actually graft, except the initial surgical part where we released that, we put skin graft on. The rest of it, the grafted skin stretched out with the distraction. And you can see again, that's the X-ray pictures as it's gone into correction, and a clinical picture. I mean, it doesn't look perfect, but a great, much better correction, and she's able to walk on this foot. The sole luckily was okay, so she went on to do quite well. So I think you can have varied presentations with these neglected injuries. I think you need to assess them carefully and then choose the nature and timing of your interventions. There'll be some situations where really doing anything will be pointless, and you end up with doing salvage procedures later. But where you can change the course of the malunion or the prognosis in the long term, then it's worth intervening. But you have to decide when and how to intervene in those situations. Thank you. It's not been very common in India, but we are seeing more and more. As you're finding younger people involved in sports, you're going to get more and more of these injuries in younger patients, and it's a lot of them get mismanaged. So I think it's important that you learn about ankle fractures, learn about the transitional fractures and the patterns that they come with in the child.
Sir, in your third case, where you have described about the growth arrest of the distal fibula, and you have asked you use the drill for destroying the infect fasces. Can you use the malleolar screw?
Yeah, you can use a screw. That's why I said either you do that or you can put a screw across the physis.
And what you have did for the distal fascial remaining part, remaining lateral part of the.
So we just drilled across them.
You drilled across them,
so that's more or less. Okay.
And sir, what follow-up here? 2 or 3 years, I think.
I think we have got a 2-year follow-up. You were actually, so he was 10 and a half, so he's 12. But you really need to follow them up to skeletal maturity. Yeah. But in 2 years, if it hasn't deformed, then the chances are it will remain okay.
Other than the Elizaro, can we use the supramalleolar osteotomy?
I mentioned, I think you weren't listening very carefully.
Yeah, sir.
I said you can do the osteotomy.
And which one, sir? Lateral?
I will discuss that. In my lecture, I will
Yes, sir.
discuss.
Yes,
Yeah.
because it appears a little bit easy than this.
No, but you can get some length with the Elizarov, okay?
That is the
So with the distraction, you get some length as well, and these will shorten up. So because although the distal tibial growth is less as compared to the proximal tibia, but they will get some shortening.
Yeah.
So with an opening wedge, you can compensate a little bit for the length.
Yeah.
Okay, with the distraction, yeah. Okay, thank you.
I think the commonest minimally displaced medial malleolus. You tend to underestimate them thinking that it's a child and it's minimally displaced. But the thing is that it's a Salter Harris type 3. It has to be perfectly anatomical. Otherwise, forget the articular congruity. The problem is the growth plate. You know, the growth plate gets malaligned, and that is going to cause a growth plate and growth arrest and further problems.
Sir, there are types of these triplane fractures which have been described, like comminuted types, 3 parts, 4 parts. So in those cases, what will be your statements? Which to deal first, which fragment to fix? What will be your sequence of fixations? How do you proceed? Yeah, triplane injuries.
So yeah, there are different varieties of triplane fractures. This was a basic talk, but yes, the CT scan gives you invaluable, information, and basically you have to plan out for each individual case. We can't have a one fits all formula for this. You have to see how the fragments are. But generally, if there are 2 or 3 fragments, what you have to try to do is first convert it into a single fragment, and then align it with the intact anterolateral fragment by rotating inward. So that would be my approach. That
So I think in the fresh cases, you can still mostly manage with closed reduction and perfusion. That's where the CT becomes important in trying to know the direction of where you put your screws.
My question goes to John, sir. Excellent presentation, sir. So, in doing supramalleolar corrections in chronic cases, do we come across the compensatory mechanisms that the foot plays? So, and how often do you have to address that?
Yeah, so for long-term problems, that's a big issue that comes in. So you sometimes need to tailor your correction to not overcorrect, because then so if you have a varus, because the foot has gone into valgus, if you get that back, you'll end up with a valgus deformity. So you need to watch your correction and stop once you think the foot is properly aligned in those. So usually these patients with the ring, you can watch them as you're correcting. So that's one advantage. If you're doing an acute correction, then you really have to try and find out how you, so you check the ankle position before you do your correction at the supramalleolar level.
One more point I want to say that what Sandeep said is correct. The malaligned fasces But with perfect reduction of physis, also supination, inversion injury, it will lead to the growth arrest on medial side. So whenever we'll see the supination, inversion injury, always say about the prognosis to the parents, because they will blame also, because they have come on first day, still it can go for the virus. So those cases will require very good follow, and then we can detect. And what he was asking about epiphysiodesis, if we do about the distal tibia epiphysiodesis, the approach is absolutely correct, because the distal tibia epiphysiodesis can lead to the 40% limb-limb discrepancy. So we have to do about the lengthening later if we do the supramalleolar osteotomy. And one more point, for a 2-part, 3-part and 4-part of triplane injury, which is the most displaced, we need to fix first. And the articular part would be given the priority, then rest of them. So whenever we do fix it, always see the epiphysis alignment is the best, articular congruity is best, then it will be rest to the matter.
First to reconstruct the articular surface and then.
Yeah. And you may sometimes have to open it, but in the fresh cases, a lot of them you can get closed. Okay, so.
Also, sir, in younger children, neglected injuries where you have a growth arrest and deformity is progressing, do you consider bar excisions? Because in post-traumatic cases, it has good results.
Yeah, but then it has to be a bar that is appropriate for in terms of size, the cause of it, etc. So if it's a huge bar, then it's no point. If it's a smaller bar, yes. And then personally, very little experience with bar, but I'm sure Hitesh would have some.
Yeah, the problem with the bar is there, as sir said, that it is to be mapped. We need to map the bar. And second, it is whether it's a central bar or a peripheral bar. Again, peripheral bar is not a good result. We'll have a central bar. And many times if you see about the shoulder arrest type 3 and 4 or supination inversion injury, that would be peripheral bar. So that is the reason the result would not be as great. And if it is associated with a great amount of deformity, we need to correct the deformity also. Otherwise, the bar excision, because growth remaining is less, particularly in adolescent. So yes, I agree with the facial bar excision, but if it is less than 25%, very mild deformity, and facial bar excision would be a good idea.
Thank you, sir. So now we will proceed with the case-based discussions by Dr. Jaswinder.
Yeah, thank you, chairpersons. So in this trauma session, I have 2 cases to show. The first is, I think, well discussed by now. So this is a 12-year-old boy, and he has an injury to the right ankle. So because this is a discussion session, may I ask chairpersons and other faculties here, so what is the injury pattern? So we see a fracture in the tibia as well as in fibula. So I'm sure everyone agrees that this is a triplane fracture. Triplane, there is associated fibula fracture also.
Yeah, and you don't have that obvious intra-articular extension, although it could be there somewhere, but you don't have that type 3 fracture line on the AP X-ray that you normally have with the triplane.
So it looks more like a type 2 Salter-Harris.
Yeah, this is that Thurston Holland sign is there with a fibula fracture. So as Sandeep sir mentioned and stressed that of course we'll get a CT scan to understand the fracture pattern. These are the CT images. So conservative versus operative.
So at the epiphysis, there is no fracture.
Yes, sir.
I mean, there is no intra-articular extension.
Yes, sir.
So this becomes a pure partial.
It is a type 2, yes, sir.
Can I ask a question?
Yeah, sure.
How is the pain of the child? That is very important and pertinent to this particular fracture.
How is the?
How severe is the symptom? How severe is the pain? Is it out of proportion?
If you are looking for, compartment syndrome, then not that much, but there was pain, of course, because of the fracture.
Okay.
Yeah, and there was there was swelling, but not as severe as a compartment types.
Because this particular fracture can cause superior extension reticular syndrome.
Okay. So moving ahead, so that is a fracture which is seen in the sagittal plane, the axial planes, and of course in the coronal plane it's not.
The question will be, would you intervene or not?
12 days. Age?
So at
Age is 12 years.
question is on the 10th day.
Boy or girl? Boy.
Yes, sir.
So he has significant growth remaining. It's a 12-day injury. You know, manipulation at 12 days, there is a high risk of causing an iatrogenic growth arrest. The displacement is more or less in the, you know, the sagittal plane. There is slight amount of valgus. What I would do is just, you know, give a molded cast, a gently molded cast. Try to correct the valgus as much as is easily possible, not apply too much force and leave it at that. Not do any, you know, aggressive manipulation under anesthesia. Try to get an anatomic alignment.
Didn't work. Actually, if you look at it, there is a displacement in the CT on the coronal plane as well.
There is that rotation also, there's external rotation in that.
Was the other thing. You couldn't get his ankle to neutral.
So those are the 3D images. We have already talked about triplane fractures. So we went ahead with the plan of close reduction if possible with percutaneous screws in this patient. And so we did a mini open type to try to reduce it. Of course, with close reduction, it was not coming. With mini open, we thought we'll pass 1 or 2 screws and wires and we might get a reduction. So that is what happened. So after trying, this was the maximum with the close reduction. We tried to put a screw, but again, after that, there was that much of gap. So we had to open it and we had to open reduce it, and that is the fixation. We had put 2 screws with kind of that washers.
What was the reason for a gap? Some callus?
There was soft tissue interposition, sir.
We couldn't actually reduce it
So we had to take out some periosteum a little bit.
eventually, but
Yeah.
closed it was not coming. Even with a lag screw, it was not coming. So then we opened it. Actually, initially we tried closed, it just wasn't coming. And then we ended up opening it.
Sir, that one is in the sagittal plane, so that can modify, I think, the coronal plane, what,
Opening up, see you retracted that and
That's what
yeah.
we found eventually.
Yep.
Yeah, 10 days, I think it was 10 days or so. It's a debatable thing.
Yeah, and
In such cases, can we do iatrogenic growth arrest for the distal fibula?
yeah, if it is causing that,
This is type 2,
if
and lateral part of the fascis is already.
Yeah, but then if the fibula doesn't grow and the tibia grows, you're in trouble, okay?
No, but the basic is to get an MRI and confirm
Yeah.
that there is a growth arrest. And if
But
yes,
that's
what you
later.
said is right.
No, but not at the time of surgery because you don't.
No, but then the question of the limbal discrepancy is going to be there. So that we have to tackle the opposite side.
yeah, we are fortunate that it is not that place. The place at the distal femur, even type 1 and type 2 injury will lead to the growth arrest. So it is, we are not talking about distal femur, but distal femur, the growth arrest is also very, very common in type 1 and type 2 injury, not even 3 and 4. So 3 and 4 and 5 definitely will lead to the growth arrest. But so we need to be really very, very aggressive in a distal femur, irrespective of any injury.
So moving to the second case. This patient had come in initial days of my practice. So this is a 9 years old female, and she had presented with a right ankle injury. So can we read? I mean, of course, there is a swelling and there is some kind of bump which is palpable on the anterolateral side, and those are the X-rays. So please, any takers for this? There is a fracture of the medial malleolus. Anything else we can see?
There's fracture
Better X-rays.
it's
Yeah,
fracture
I'll show you.
dislocation of the talus.
So those are the better X-rays, sir. So there is a talus fracture with a medial malleolus fracture, and the talus is quite comminuted.
Dislocated.
Sir?
It's dislocated as well.
Dislocated with that fragment of the talus which is on the anterior lateral side. That bump was felt. It is kind of the ankle was locked in that position. I tried to manipulate for a close reduction in the emergency. It could not happen, so that I just wanted to put it back because the ankle looked dislocated. Yes, sir. So those are the CT images. She's 9 years. So how do we?
Which approach is an important question, because there is no doubt about that we have to reduce it. But which approach?
Medial malleolus is fractured. That would be that would be your best approach, isn't it? A medial, anteromedial, and then you might have to add a lateral approach.
The problem is the fragment is locked on the lateral side. So in spite of, yes, it gives a window, the medial osteotomy, malleosus osteotomy is already there for us to enter. But with that also, we could not, I mean, there might be a possibility that we are not able to open reduce from the medial side.
Yeah, but we can do, because medial malleolus is already fractured, we can go from there because we have to fix the medial malleolus. And we can use about the joystick to bring that fragment out. It can happen also from the medial side.
Right, sir.
From the medial side and put about the threaded bit on the.
I think a distraction is very important in these. So you use a distractor across the ankle.
And you invert, no? Supinate and invert the lateral piece you can see.
So talus fractures in children, they are quite rare. It is 0.008% of all childhood fractures, and it results from an axial loading of talus against the anterior tibia with the foot in dorsiflexion. And because the pediatric foot is flexible and less brittle as compared to the adult, and that is why they can sustain higher forces before they get fractured. The site, the talar neck is more common than the talar body. Of course, for the undisplaced one, we can go for cast immobilizations, and there can be complications like, as in adults, there can be avian arthrosis, delayed union, and neuropraxia. So I started with a medial approach. I could not reduce it, and then so I had to add an anterolateral approach. So this was on table. I tried to reduce it against in anesthesia also. It was not possible to reduce it. So that is on the medial side. We started with that. There is a fracture. That is on the lateral side. That is the proximal talus fragment, which is kind of dislocated and locked on the anterior lateral. That is a fibula. And that is a fracture there. So, fixation, sir.
I generally like in a talus body fracture, this one I like to have a herbert screw because there is all that everywhere headless screw because everywhere is a cartilage. Put from the corona from medial to lateral. Which fragment is big, you can use it.
And it is quite comminuted at the same time. Yeah.
You can use about the wire also, but the wire will be very, very prominent.
And get as close to an anatomical reduction as possible. In this case, it may not be 100% possible, but you have to try to get the best possible reduction. And then the screws fixation would be with screws. If it's through the articular part, then it has to be countersunk or headless screws. If it's through a non-articular part, then you can use regular screws.
So as said, I did everything, but there was something wrong here, or maybe I would not have done. I fixed the talus with screws. That is how I fixed it. I got a reasonably good reduction intra-op, which I could see. That was for for the fibula, that one screw I'd passed horizontally, but I should have passed a wire. That was in my initial days of practice. I did not realize, and I passed a screw there. So of course that either this might have later on.
Can you just go back to the first X-ray?
So these
No,
are
the first X-ray. Okay, so there's no metaphyseal portion to the fracture.
There was a small metaphyseal
Small,
peak
yeah.
there, sir. Yes.
Which cannot be fixed with
I should have, sir. That is what I'm saying. So that is just the intra-op images, and of course I added a fixator just to keep it in a little distraction mode. Those are the post-op images, immediate post-op. And then when I was about to remove the fixator, this is at 3 weeks post-op. At near about 6 weeks, I took out the medial malleolus screw also. I mean, it was with near the fixator, that is near about 4 weeks, I took both of them out together in the OT. So this is roughly 6 weeks post-op. That is only one image I have at 3 months, and that is at 1 year follow-up.
Growth arrest on
Yeah.
that side.
So the growth arrest maybe because of I had done it, or might be it is because of the initial fracture pattern. I had explained from the beginning that there might be a growth arrest, so the patient father was quite ready to accept that. And recently, very recently, he had sent this is at 2 years follow-up, implant removal had been done. After this, I don't have x-rays because he doesn't want to get any new x-rays done. But that is the last follow-up at around 6-7 years after the initial injury. As such, she is very happy. She has no pain, no complaints at all.
Yeah, so she was very close to skeletal maturity already.
So, Jaswinder,
So the message to all the young people: do not cross the physis with a screw. It can cause a permanent damage. Put a wire. Yes, please, Ritesh.
So, what was the sequence? Means you fixed talus first or the tibia first?
I had a window for the fixation of I did talus fixation first, followed by malleolus.
Because it's important here to maintain the relative width of the distal tibia and talus. That is also an important.
See, my concern was first getting a good reduction for talus, and I of course had put the incision on both the sides. At the same time, it was quite a comminuted fracture. It was not like I could have done a percutaneous kind of thing, So I reduced talus, fix it with screws, finish my talus fixation, and then finish the tibia part.
Usually what I prefer is to fix the less comminuted fracture first.
No, but in adults, in fact, osteotomy of the medial malleolus is an approach to the talus. So, if your medial malleolus is anyways fractured, it gives you good exposure to the talus. You fix the talus, and then the medial malleolus can be fixed comfortably.
Because that's helping you access to view your reduction of the talus. So if once you fix that, you're not going to get that direct views, because especially the body is also involved. You need to visualize that part. And that is where the medial malleolar osteotomy helps you. Okay?
Okay, right. Any more questions? Yeah, Dr. Open. It was a neck fracture, and it was, and it was comminuted also. Neck.
It extended to the body. It was not
extended to the body, it is a comminuted.
Yeah, he did. By this way, sir, we can reduce the talus very easily, and up to 100% reduction we get by 2 incisions. Rather keep 1 incision, sir, as we have.
So nowadays, no, this is 2 incisions.
Yeah, this is one.
Anyway, for most talar fractures, they recommend incisions for the reduction.
Yes,
okay, in adults, anteromedial
Yeah.
and a lateral incision first, because if you put compression screws on the medial side, you end up putting the talus into varus.
Yeah.
And that causes problems long term. So the recommendation today is that if you put compression screws, you put it on the lateral side, and then on the medial side, you would put fully threaded screws, or sometimes, or you can put a small plate on the lateral side and then fully threaded screws on the. So you do not want to compress the medial side, because then you get a varus of the neck of the talus, and that causes problems later on.
Thank you, sir.
Okay, so we are on time, and if we don't have any more questions, we'll end this session now. May I thank the chairpersons. The faculties will be felicitated later also. For the next session is deformity session, and for the next session, the chairpersons. Dr. S.P. Gupta, sir, please come on the dais. Dr. Dinesh, please. Dr. Nand Kumar, sir. And Dr. Ravi Shankar is there? Ravi? Huh.
Request Dr. Dhiren Gunjwala. Hello, Dr. Dhiren Gunjwala. Please.
We are going to discuss in this presentation, the first, what are the causes why we see coronal plane deformities, how to evaluate them, and the last thing about management. So first of all, causes. Now we need to remember that this deformity can be above the ankle or below the ankle, means at the subtalar joint. So the most common cause are infection, post-traumatic, like we discussed a lot about that in the previous session. The exostosis will reduce the growth on one side, and that leads to angular deformity. Or like we discussed yesterday about the paralytic condition, spina bifida or cerebral palsy will also lead to this deformity. So this is a case where a patient had a road traffic accident and there was a severe soft tissue skin loss, and that resulted, like, which was treated well, but ultimately that leads to a varus deformity. We already saw a similar cases in the previous session, so now we all are aware about this. This is about exostosis, where a big exostosis both from the lateral aspect of distal tibia and the distal fibula will result into a growth arrest, reduced growth on that side, not growth arrest but reduced growth on that side, and that will lead to a valgus deformity. This is another case where there was an infection and that resulted into the loss of physis or severe problem with the growth, and that resulted into the severe varus deformity. Now this case shows that why we need to treat fibula, because we can see that it has resulted into a problem. So if we are watchful, then we can avoid this deformity going to this extent. But yes, in India we see these cases very frequently. Then we see the below the ankle joint, and that's valgus at the subtalar joint. Usually that's a valgus at the deformity, not varus. But in a paralytic condition, we may see varus also. So the most common one, the flexible flat foot, which we discussed yesterday. The tarsal coalition is another problem which we see at that area. Or sometimes overcorrected clubfoot, not with the Ponseti, but with the previous surgeries which were very popular, complete subtalar release, where 20% of the cases were going for overcorrection, and in those cases we used to see this problem. And we will see something about spastic planovalgus foot, which is very common in cerebral palsy and spina bifida. So this is a case of flexible flat foot, where we can see the complete loss of medial arch. This is a case of cerebral palsy, where there is an extreme valgus. On one side it is more than the other side. This is a spina bifida having a severe valgus fit deformity. So the next question is, why should we treat this? This is a very important, because when it comes to explaining the family, we need to tell this to the family. The first is cosmesis. But a lot of people say that anyway it's going to be hide in the shoes or underneath the trouser. Why we need then cosmesis correction? Yes, in that case, basically that leads to shoe wear. Fine, that is also like we are ready to buy few pair of shoes at every few months. That's not a problem. But in over a period of time, that abnormal weight bearing leads to callosity and then pain. This will not happen immediately, but may happen after 10 or 15 years down the line. And osteoarthrosis of the ankle joint or a subtalar joint, again in the future. So pain may not be present at the time of presentation when they come to us, but may appear later on. And one of the reasons could be osteoarthrosis of that joint due to the abnormal loading. How we evaluate them? The first and the basic one is like we look at the clinical point and we look at the range of motion of ankle and the subtalar joint. We ask the child to stand on the toes. There are two things happening when the child stands on the toes. The first, the tendo Achilles is relaxed. So whatever is a component of tendo Achilles, that is taken away. And the second is like when child is standing on the toes, there is a hyperextension of the MTP joint, metatarsophalangeal joint. So that causes a jack test. So again, that tightens the plantar fascia, and particularly in the flexible flat foot, this is a very important test. And the most important thing, if we are thinking of a surgical correction, then radiological assessment is very important. So this is a case where like a child had a valgus deformity and a flat foot, and the same child when standing on the toes. Now what happens with plantar flexion? The tendo Achilles is now relaxed because the foot is in plantar flexion, and the jack test is also being there. And now we can see that now hind foot goes into varus. So the important information is that this is a flexible deformity. There is a correction taking place at the subtalar joint. So this is a flexible variety of the deformity. Coming to the important part, the radiological thing, we need to take a standing AP and lateral view. But the important thing is like this helps us where is the deformity if it's present. So that is the most important information we get. It also tells us about how much is the deformity, which is very important for us when it comes to the surgical correction. So these are the AP views which tells us that what is the reason of deformity, how much is the deformity, that information we get. So for that we draw a line passing through the shaft of the tibia, and we draw a line parallel to the articular surface. That's a distal physis. If it's a unilateral deformity, the normal side becomes a useful information for us, and we can compare it that this is angle, the distal lateral tibial angle is 87, and we can compare that on this side, there is a 120 degree. So almost 33 degree deformity is there. So this view gives us idea about the amount of angulation at distal tibia. This is useful for the deformity which is above ankle joint. If the deformity is below, then we need to go for a spatial view, which is a hind foot view for looking at the amount of deformity. So how we take a hind foot view? So let's take this is a foot. We keep a plate at 20 degree to the vertical line. So this is a radiologic plate, and the X-ray beam comes perpendicular to the plate. So this is the view which gives us information about hind foot. The previous view which we saw is good for the above ankle, but it does not give us any information for the deformity when it is below ankle. So this view is very important, and we try to look at this view, and we look at this is a long axis of distal tibia, and this is an axis of calcaneum, and that gives us the idea about how much is the problem at the subtalar joint or below the ankle, not subtalar joint but below the ankle. Coming to the last part, that's a treatment. The options we have is a non-operative treatment or a operative treatment. I'm going to focus mainly on the operative line of treatment because non-operative treatment is just as a compensation. We can give a weight sole, but it does not correct the thing. It's just a compensation. So for the operative line of treatment, we have two options. The first is growth modulation, and the second is osteotomy. We cut the bone and correct the deformity. So let's understand the concept of growth modulation. This is a valgus deformity at the distal tibia. We put a screw like this. Already the case has been shown probably yesterday. So the same thing, like we put a screw on the medial side, we are reducing or stopping the growth of a medial distal tibial physis. So the lateral side will continue to grow, and over a period of time, the deformity will get corrected. So this is the deformity. There is a valgus deformity. This is how the screw has been inserted from the medial malleolus, a very easy procedure. And over time, the deformity gets corrected because the growth will take from lateral side of the distal tibia. And this is the final thing. We need to remove the screw. Now, one thing is very important, that the cause of the deformity is still there. So we need to keep them under follow-up because there may be a recurrence of the deformity. And if it takes place, then we need to intervene again. The question is like, what about leaving it like this, keeping the screw? If we keep it there, then again it will lead to overcorrection. So that is also not advisable. The advantage of this procedure is like, because it's a small procedure, on the third or fourth day, child can start walking as soon as the pain is taken care of, and there is no immobilization at all. So that's a very good procedure from the patient's perspective. The word of caution, the distal end is slowly growing. So don't expect a rapid correction. Usually the correction will take 2 years or so, depending on the amount of deformity. And the 3 years growth must be there. Then and then we can expect some correction. This becomes very important for some of the cases which we discussed, particularly that is in a female patient. Then they don't have adequate growth. Then in spite of doing a procedure, we will not get a complete correction. So this is one point which we need to remember. Coming to the osteotomy, Dr. Jasar asked about that, and this is what we need to understand. It's a wonderful procedure. On table, we get a correction. So it's very satisfying to the surgeon. The question which comes when we are dealing with the distal tibia or the supra ankle deformity, should we cut the fibula or not? And how should we fix? So let's see, this is a supramalleolar osteotomy. Let us understand like that. If this is a deformity, there is a valgus thing, we need to draw a line which is perpendicular to the tibia, the long axis of tibia. This is axis, the line which we draw perpendicular to the physis. So this is the amount of correction which is required. We take out, or before we take out the bone, we need to cut the fibula at the same level, because fibula will not allow the deformity to correct. So we take out the triangular wedge and then we correct the deformity. So this emphasizes that it's important to cut the fibula at the same level. Coming to the question about the deformity when it is below ankle joint, we try to, or we can correct it with the calcaneal displacement osteotomy. So if this is the deformity like this, in that case, we can cut the calcaneum and we can displace it and shift it medially so that it comes underneath the line of weight bearing. We can also carry out a calcaneal angular deformity, and in which we take out the wedge, we cut the bone and then we rotate the distal fragment and we put a graft in the gap. So these are the options available to us for correction of the deformity. So in short, the coroplan deformity, it can be at two sides. It's very important that we decide whether it is above ankle or below ankle. The X-ray helps us to identify where the problem is. Growth modulation has a role, very good technique, but it has a role in a very small number of cases. It's not a panacea. And if that is not possible, then we can definitely correct it with appropriate osteotomy. Thank you. Just I.
धीरेन गांजावाला हाँ अच्छा अच्छा कौन है डॉक्टर
May I request Dr. Sandeep Paedya?
Yes.
Please come.
Foot and tibial hemimelia, I'll say the tibial hemimelia is exceedingly rare tibial deficiency. Because the talk is there, I am going to say that. And we are fortunate to have its deficiency of the tibial long bone is very less, because it's not very easy problems. So I am going to give the rough idea about the foot deformity in a tibial deficiency. Whenever there is a tibia is absent, the medial side of the race would be absent. And whenever the lateral side of the leg long bone would be absent, like the fibula is absent, the lateral rays would be absent. Sandeep is going to talk on the fibular hemimelia, so I am not going to go in a fibular hemimelia. But its important aspect in fibular hemimelia, the clubfoot is exceedingly rare. Very commonly it will go in valgus and equino valgus and lateral lay deficiency. On the contrary to the fibular hemimelia, the tibial hemimelia, the foot deficiency is very, very different. It can go with the deficiency, it can go with the duplication, it will go with the triphalangeal term, it can go with the three triphalangeal, three phalanx will be there. It's a very different spectrum is there, though it is actually exceedingly rare, the deficiency. It's not very, very common to have a deficiency. But the main focus of the surgeon would be saying that whether he can salvage and do about reconstruction or he can do about ablative surgery. So the main focus is on the leg, not on the foot. If ankle and foot would not be the first priority of the treatment for the tibial hemimelia. So the priority of the reconstruction versus the limb ablation would be of the tibial hemimelia, whether it's a what type is there, type 1, type 2 and type 3. So that is very important. I will include that in the different parts of the talks on that. So by and large, the tibial hemimelia, there are the various classification, but not confuse that. We put a very, very simple classification is the whether the tibia is completely absent, whether tibia is partially absent, or whether tibia is the diastasis between tibia and fibula. There are the multiple classification is there, Kalamchi, Weber, Jones. I am not going in detail. Common is that whether it's complete absent, partial absent, or distal tibia fibula diastasis. This is very, very simple to follow on that. What happened in case of the pendulum of tibial hemimelia moves, if you read the literature, whether you do the limb ablative surgery or limb salvage surgery, the people who are there from the complete tibial hemimelia will say very simple, we can do about ablation because quadriceps is, the tibia is forming the knee joint and ankle joint. If complete tibia is absent, the ankle is unstable, knee is unstable and quadriceps is not working. So simple thing is that do about the disarticulation of knee because it will be a single surgery and lead to the less cosmetic as well as the psychological problem to the patient and parents. If you do about reconstruction, it will require the multiple surgeries and it is a very, very prolonged and ultimately the child will walk with the brace, not about the prosthesis. The pendulum or the trends of the tibial hemimelia moves from the reconstruction to the ablative. So the reconstruction, it's initially described by the Putty and Brown in the literature, but then Loader said both of them doesn't work very well and ultimately it require about the amputation. However, after that is a few population from the Japan and as well as the Europe, they said they don't accept the amputation. So they tried about the reconstruction. So there are the few articles came there about the knee reconstruction and the limb salvage for that. But I'm not going in that detail. I want to just sensitize it is the different spectrum of the limb ablative versus the salvage. So by and large, when there is a complete tibial hemimelia, when quadriceps is functioning and there is a flexion deformity is not severe, we can think about the salvage. Salvage means it's tibia fibula reconstruction, fusion and the Brown's procedure. But Brown's procedure will also have their own problem. So it's like that. It's a type 1 tibial hemimelia. Tibia is completely absent when there is a duplication of toe. There is a both side. There is a duplication of the mirror image duplication. It's called as a preaxial polydactyly. We can do about the reconstruction. And because the quadriceps is working, we can see the quadriceps is working. In this child, we have done about reconstruction. I will show you about that. And the child is standing. Because it's a quadriceps is working, very few deformities there. We remove the extra rays on the medial aspect, the preaxial polydactyly, and the child is on the both side, not on one side. When the tibial hemimelia, again type 1, there is no functioning quadriceps. Quadriceps is not functioning. There is severe amount of the flexion deformity. There is no role of doing about the reconstruction. Again, Weber, Palais, as well as Dr. Vada has doing about reconstruction, but average number of surgeries require 8 to 10, and then the lengthening also will be really problematic if it is unilateral. So it's a simple surgery is do about disarticulation. When the complete tibial hemimelia with shortening of the femur or a PFFD, you can do about the fusion of the knee joint and amputate the foot. Then the put about the prosthesis like a knee disarticulation type because it will be associated with the PFFD.
What would be the treatment for the type 2 when there is a partial tibial hemimelia, where there is a proximal part of the tibia is present and where there is a moderate amount of the deformity is there, but no ray is missing? You do about a reconstruction in terms of the tibia fibula fusion and the limb lengthening. Like this child's, where you can see on that the right side there is a severe tibia, distal tibia was absent. We did about the tibia fibula fusion and do about the lengthening. We have the long-term follow-up. This child is quite good. When there is a partial tibial hemimelia with a severe shortening with rays are missing, when there is only 1 or 2 rays are there, it's not a stable foot. We can do about amputation at the same amputation or the below knee prosthesis we can put about that. So like this, where there is a glossally deformed with only single ray is present. This is the example where there is the type 2 hemimelia where the only single ray is present. There's only 1 ray is there. So we can do about the amputation, tibia fibula fusion, and about do the Sims amputation, and the child can walk with the below knee prosthesis. Type 3 will be having the distal tibia diastasis, where there is a tibia and fibula is fused, and do about the limb lengthening later. That will be, I'm not giving example of that. But these are the overall by the type of the deficiency. But there are the more pattern. Pattern would be there whether the tibia is completely absent, if we associated without duplication. Without duplication means there will be 5 rays would be there without form elements, or it will be present with the duplication of the form element. It will be more than 6, 7 or 8 metatarsal and phalanges would be there. Or that may be the partial tibial hemimelia would be present with the 5 rays or 6, 7, 8 rays with duplication or without duplication. Or will be having with the tibial dysplasia. Depends, the tibia is dysplastic in shape. So first, complete, incomplete or dysplastic, then say the without duplication or with duplication. We'll see about example like this is a dysplastic tibia. Tibia is trapezoid in shape, and we found that it's along with the trapezoid tibia there would be duplication of talus and the form elements. It's very, very common. Trapezoid, the duplication will be there on a pre-axial with the duplication of talus, and duplication of the fibular diamelia will be associated with the duplication of the calcaneum. So this is an example, the complete tibial hemimelia with the without duplication. We can see there is the medial side is absent, equinovarus is there, the great toe is shorter, but that all the toes are there, all 4 toes are there. And this is the X-ray, that's a pre-axial polydactyly where there is a with duplication, where there is a tibia is absent, but we can see the number of rays. In the X-ray, you can see the 7 rays are there. That this is a hypoplastic metatarsal. The first ray is hypoplastics. This is the X-ray where there is a pre-axial polydactyly with the mirror image or the mirror image duplication. Exceedingly rare to have the duplication of fibula, that is called as the fibular diamelia. This is a case, tibia is completely absent, but the fibula is double. Where there is a fibula is double, it will be common with the lateral rays would be duplicated. Lateral rays would be double calcaneum or sometimes double cuboid, and there is lateral metatarsal. It will be very, very common with we can see here, there's a single talus and side there are 2 calcaneum. That will be present with the mirror image duplication of the polydactyly. Single part will be, central part is there, but it's a mirror image. Central is the first ray, laterally and medially both are the metatarsal. Duplication of calcaneum cuboid or a lateral cuneiform. That will be the image with the fibular diamelia, and there would be single talus. These are the clinical pictures of the fibular diamelia. What will you do then? A partial tibial aplasia, there will be normal toes, all 5 toes would be there, or the rays would be reduction. There will be reduction in a rays. Or it may be sometimes would be duplication of the toes. We can see the duplication on the metatarsal type or a phalangeal type. Or duplication of talus. We can see there will be double talus here also. Or the fused talus. In case of the dysplastic trapezoid, the pre-axial mirror polydactyly will be duplication of talus with the duplication of the metatarsal would be there. Again, we can see the single calcaneum and double talus. We have dissected, fortunate enough to dissect the few cases which go on to the amputation. We see that endoachilles inserted more medially in here. Sometimes tibialis posterior would be the absent or would be passed superficial to the flexor retinacular tibial nerve, and the posterior tibial artery would be superficial to flexor retinaculum, and there will be abnormal standing structures would be present. Similarly, the same tendinous structure will be work as a tether, and if we by chance we go for the reconstruction, this would be the helpful. And these similar things were present by the arteriogram, because sometimes it will be tibial artery would also be the absence. So these are the implication for the reconstruction. I will end my talk on here, because these are the important parts where we can see there will be 5 toes or more than 5 toes, or that may be absent toes in case of the tibial hemimelia. Thank you.
A speaker is Dr. Sandeep Baidia. Please.
Okay, so I am going to speak about fibula hemimelia. And unlike tibial hemimelia, fibula hemimelia is much more reconstructible as compared to tibia hemimelia. But still, there are situations where you have to take a call, are you going to, reconstruct the foot, or are you going to ablate the foot, or are you going to do nothing, even there are circumstances where you would do absolutely nothing. So I am not going to focus on the surgical technique, okay? I am only going to focus on the decision-making process, and because that is what is most important for you. So fibula hemimelia, we all know it is a congenital deficiency with partial or complete dysplasia of the fibula. So it has been proposed that it has a vascular etiology, okay? The blood supply to the growing lower limb in the fetus, that is affected, and therefore it is not just a problem of the fibula, it is not just the fibula that is affected, it is a problem of the entire lower limb. So you have a Legalin discrepancy, you may have an associated congenital short femur, in fact many times you do have a short femur associated with it. You have a knee instability, which is because of absence of the cruciate ligaments. You have a genu valgum because of hypoplasia of the lateral femoral condyle. Then you have a tibial shortening and deformity, and finally, the topic of discussion today, you have the foot and ankle deformities. So what do you have in the foot and ankle? So again, in the foot and ankle, there is a range of problems that you can have. You can have a ball and socket ankle. You can have an ankle valgus. Many times you do have a subtalar tarsal coalition, which is again malunited. So there is a coalition at the level of subtalar joint, which is malunited. Then you have an absent lateral raise, and the deformities, in terms of deformities, you can have either have a equinovalgus foot, or you can have even have a club foot in some circumstances. So, a fibula hemimelia, the foot can come in various shapes and sizes. And because there is such a varied presentation, it is important that we classify them, and more importantly, the classification should guide us regarding the treatment to be adopted, the treatment modality to be adopted. Now, the earliest classifications that were described, these were described in the 1960s and 70s, that is the Coventry Johnston and Achterman Kalamchi. They basically were based on the percentage of absence of fibula. However, these classifications are not of much use clinically, because our decision making is not at all based on how much of the fibula is absent. It is based on, something much more than that. So this was a more comprehensive classification, came out in 2003. In addition to the percentage of absence of fibula, what this classification, the Stanitsky classification, took into account is what is the orientation of the tibiotalar joint, is there a tarsal coalition, and what are the number of rays. But from point of view of treatment, the two classifications that are most useful according to me, the first one of that is the Birch classification described in 2011. And there are 4 things that the Birch classification took into account. How many rays are present? Is there an associated congenital short femur? What is the leg length discrepancy measured as a percentage of the opposite limb? And are there any associated upper limb anomalies? So how the Birch classification is useful in treatment decision making, we'll come to that in just a short while. But apart from that, the other decision, the important classification in terms of treatment decision making is the Pally's classification, because if you choose to reconstruct that foot, the Pally's classification guides you as to what exactly is the reconstruction procedure that you are going to adopt. And we'll discuss this in a bit detail in a few minutes. So how do you make your treatment decision making? So there are mainly 2 main things that you need to consider. Are you going to reconstruct this foot, or are you not going to reconstruct this foot? And if you are going to reconstruct, how are you going to reconstruct? So the first question to reconstruct or not to reconstruct. And the Birch classification gives you a good treatment algorithm for that. I have attached the chart over there, but to simplify things, let's see what are the Birch recommendations. And I find these to be very logical, okay, very logical and very practical. So the first step is differentiate between the reconstructible foot. So what is a reconstructible foot? Very simple. 3 or more rays is reconstructible. 1 or 2 rays is not reconstructible. So if the foot is reconstructible and the leg length discrepancy is less than 10%, you definitely should reconstruct that limb. That's the first rule. If the foot is reconstructible and the leg length discrepancy is more than 30%, you should not reconstruct. However, with a reconstructible foot and a leg length discrepancy between 10 to 30%, that is a bit of a gray zone. And here the decision making depends on multiple factors like the surgeon's skills, the available resources, the financial and the social situation of the family. That is perhaps one of the most important factor in our country. Non-reconstructible foot, how do you manage? So you have a non-reconstructible foot and the upper limbs are functional. In that case, you would do a Symes amputation and fit the child with a below-knee prosthesis. On the other hand, if you have a non-reconstructible foot, that is only 1 or 2 rays, and the upper limbs are not functional, then the lower limbs, the foot might be useful in performing some activities, some prehensile functions of the upper limb, and therefore you should try to preserve the foot in that case. And in those cases, rather than doing a Symes amputation, just apply a simple extension prosthesis. So you preserve the foot and apply an extension prosthesis. And most importantly, in our country, take into account social issues. Especially if the child is going to need 2 or more lengthenings, are they going to be able to afford it? Where do they stay? Are they coming from a remote area? These all things have to be taken into consideration, and you have to discuss with the family. What are the non-reconstruction options? So I mentioned that there are 2 options. So if the upper limb is not functional, you would probably preserve the foot and you would apply an extension prosthesis. And the upper limb is functional, then probably you would do a Symes amputation and apply prosthesis. There have been studies which have compared the results of amputation, Symes amputation and prosthesis versus extension prosthesis. And what they have noted is the amputation with below-knee prosthesis probably has a better functional outcome as compared to an extension prosthesis. Now coming to the reconstruction options, and for here I have probably, in today's day and age, the go-to, article is this one by Dror Pally. It came in JCO 2016. It is an extensive article, almost a 35-40 page article, in which all the reconstructive options, the surgical techniques have been described in great detail. I am not going to go into the surgical details. What I am just going to tell you is the principles of treatment. So basically what you have to do over here is you have to identify all the problems. So talking about the foot and ankle, what are the bony deformities that can be possible? First of all, there is a distal tibia bowing that can be present. Then there can be an ankle valgus. At the subtalar joint, many times there is a collision, as I mentioned earlier, and this collision most often it is malunited in a position of equino-valgus, but in some cases it can also be malunited in a position of clubfoot. Okay, so identify these, and these need to be corrected. Also, you have to release the tethering soft tissues. So what are the tethering soft tissues, main tethering soft tissues in case of a fibula hemimelia? You have a fibula enlarge. What do I mean by fibula enlarge? So the fibula is absent, it cannot be seen on X-rays. However, there is a thick fibrous remnant of the fibula which is still present over there. And what this enlarge does is it tethers the ankle and foot into a position of equino-valgus. So you have to correct a foot and ankle deformity, you have to excise this fibula enlarge. That is an essential part of the procedure. Peroneal tendons, many of these cases, they are short, tight and fibrosed, and they need to be lengthened or released. Gastrosoleus, again, it can be tight or contractured and it needs to be released. Now coming to the, type-wise, what procedures should be done. So type 1 is basically a normal foot and ankle, and no procedure needs to be done for the foot and ankle. In type 2, Paley's type 2, this is a dynamic ankle valgus, meaning that the child does not have an ankle valgus deformity at rest, but on weight bearing, the child develops an ankle valgus, and here Pally has described what is known as the short procedure, which is the acronym for shortening and realignment of distal tibia relative to fibula. I would recommend you to go to the article and read this technique if you ever plan to do this. Type 3 and 4. So these have subtalar coalitions which are malunited in either equinovalgus in cases of type 3 or in clubfoot position in case of type 4. So here you have to do what is known as the super ankle procedure, and basically it consists of supramalleolar shortening plus realignment osteotomy of the distal tibia. Subtalar osteotomy. So this osteotomy is through the coalition, through the tarsal coalition. So just like you do a calcaneal displacement osteotomy, which has been earlier discussed, here this is an osteotomy through the subtalar coalition or through the subtalar joint, which is not actually present in this case. And of course you need to do the soft tissue releases along with that, mainly excision of the fibula enlarge. Just to give you a few case examples, so this is a child with a fibula hemimelia where you can see that there is a subtalar coalition which is malunited in an equinovalgus position. What we did in this particular case is we did the superankle procedure, which is excision of the fibula enlarge. Then we did the tibia osteotomy, and plus we did the subtalar osteotomy and corrected that equinovalgus. This is a follow-up, and the child has later on undergone a lengthening, and the first lengthening has been done. He is around 7 years old, but he is going to need a second lengthening sometime in the near future. Another example, now this was a child who was almost 8 years old, never sought treatment before, came to us, and you can see that she is walking almost on the dorsum of the foot. The ankle is completely dislocated. Now looking at the position of the foot and ankle and also the social condition, the child is coming from the remote area, there is no point in preserving this foot and ankle. What we opted to do here is a Symes amputation. Okay. So to conclude, foot and ankle problems in fibula hemimelia can be varied. First step is identify which feet you are going to reconstruct, apply appropriate reconstructive techniques for these feet. Non-reconstructive techniques can have good functional outcomes if appropriately chosen. Thank you.
May I request Dr. Ritesh Pandey?
So I will be speaking about pediatric hallux valgus, and it is very important to realize that it has lot of differences from an adult hallux valgus, and we should keep in mind these peculiarities and treat these children accordingly. So we will discuss how they are different from an adult hallux valgus and how we should proceed towards its management. So hallux valgus is a lateral deviation of hallux and medial prominence of first metatarsal head, and the incidence is much more in girls with a ratio of around 10:1, and according to the age at onset they can be congenital, juvenile or adolescent. Radiographically, the hallux valgus angle is increased, and it can be grouped into mild, moderate and severe types. Similarly, the intermetatarsal angle between the first and second metatarsal is also increased, and anything more than 9 degrees is considered abnormal. And contrary to the etiology in adults, in children mostly they will be idiopathic, that is the cause cannot be discovered, and in few cases an underlying cause can be identified, of which neuromuscular and connective tissue disorders are most common. And then you have other less uncommon etiologies like post-traumatic or in association with flat foot or genu valgum. It is also important to realize that onset before puberty usually have an underlying cause, and one should look for that underlying cause, whereas onset around puberty is mostly idiopathic and post-traumatic. So how is it different from adult hallux valgus? So the first important thing to realize is, in children usually the joint, the first MTP joint is congruent, whereas in adult there is incongruity which is giving rise to the deformity. In children on other hand there is lateral tilt of the distal articular surface of the first metatarsal, whereas in adult that is usually not the issue. And this can be appreciated by an increase in the distal metatarsal articular angle and the proximal articular set angles. The other important difference is that the varus of first metatarsal can be because of a medial tilt in the articular surface of the medial cuneiform. But more common in children is its association with metatarsus adductus, where the central metatarsals are also deviated medially, and in these cases you won't get an increase in the intermetatarsal angle. Then there are other differences like a lesser deformity, smaller bunion, the joint is usually not arthritic, and you have a growth plate, which because of which there is risk of progression of the deformity. It limits the surgical options. There is remodeling potential and hence the risk of recurrence also. However, it offers you the option of growth modulation. So it is very important to keep in mind these peculiarities and not to treat the children similarly as adults. And the treatment can be discussed in two groups, that is before maturity and after maturity. Before maturity, conservative management is the treatment of choice, as the surgery has a very high recurrence rate, which is reported in literature up to 61%. However, early surgeries can be considered for syndromic and neuromuscular deformities in special scenarios if the conservative treatment has failed and the deformity is progressive, or if it is symptomatic and painful. And it consists of combination of interventions like bracing, stretching exercises, activity modification, footwear modification where you give wide toe shoebox, and orthotic inserts can be helpful if there is concomitant pace plainness. And different bracing protocols have been described which depends on the age at treatment. Growth modulation is an attractive option in this age group. However, these techniques have not been widely used and it needs proper validation. And when chosen, it can be done in different ways, like you can go for percutaneous drilling of the lateral physis, or you can choose a screw epiphysiodesis, hemiepiphysiodesis. A double level hemiepiphysiodesis has also been described, which consists of intervention in the proximal phalanx and the base of first metatarsal. However, the results of this double level epiphysiodesis is equivalent only to the single level epiphysiodesis. So this was a case of a 10-year-old boy with hallux valgus, and a screw epiphysiodesis was chosen here, hemiepiphysiodesis, and at 2 years follow-up we have satisfactory results. However, it is important to realize that the rate of correction is very, very slow, and it is around hardly 2 to 3 degrees per year. So you need to have enough growth potential remaining if you are going for this modality of treatment. After maturity, the treatment consists of definitive deformity corrections, and a number of procedures have been described in literature. However, there is no consensus about the single superior treatment. So I won't be going into details of all these procedures because of the time constraint. So they can be grouped into soft tissue procedures. Usually these are not done in children, and they can be added if you have an incongruent first metatarsophalangeal joint. Then you have different type of distal osteotomies, of which Akin osteotomy is widely described. It is done at the level of proximal phalanx. Then you have osteotomies in the distal metatarsal. Again, different types have been described. So these take care of the deformities which are located in the distal part of the foot, like in proximal phalanx or distal first metatarsal. And this distal M1 osteotomies, it corrects the lateral tilt of the distal articular surface, which is a peculiarity in children. Then scarf osteotomy can be done in the diaphysis, and then you have proximal osteotomies either in the base of the first metatarsal or in the medial cuneiform. In case of concomitant metatarsus adductus, you need to correct the deformities in the central metatarsals as well, because that will not allow the first metatarsal correction if it is left untreated. And then you have fusion procedures which can be done alone or in combination with an osteotomy, and it is ideally indicated for neuromuscular or syndromic cases, or if the joint is painful or arthritic. So as we can see, these isolated procedures are not self-sufficient, and they take care of only a part of the problem. So it is, they are normally or very commonly used in combinations as per the case scenario. Also, the minimally invasive techniques are becoming more popular because they offer limited tissue dissection and less surgical time. So the current trend is to use a la carte approach, where a combination of osteotomies are chosen depending on what deformities you are facing in that particular case. So here is a stepwise approach. If there is distal metatarsal articular angle is increased, that is, the deformity is in the distal metatarsal, and you have a lateral tilt of the distal metatarsal articular surface, you need a distal metatarsal osteotomy. For the correction of M1 varus, you will have to add a proximal metatarsal osteotomy. In some cases, both these problems can be taken care of by the scarf osteotomy, which is in diaphysis, but it has again its own limitations. And if you are facing a concomitant metatarsus adductus, then the central metatarsal osteotomies also needs to be done. Then adjuvant procedures, they are not done routinely, but they can be added if the case needs it, like bunionectomy, soft tissue procedures, and a proximal phalanx osteotomy if you have hallux valgus interphalangealis. So this was an example, a 22-year-old female. We can see a hallux valgus and presence of metatarsus adductus with a almost normal intermetatarsal angle. So here the osteotomy of the center metatarsals were done, and the first ray deformity was corrected by a distal metatarsal osteotomy and a Keen's osteotomy. And these are the results after 9 months, showing a satisfactory correction of the deformity and healing of the osteotomies. So to conclude, this algorithm can be followed where all the cases receive a trial of conservative treatment, and if it fails, appropriate surgical procedure can be chosen depending on the age of the patient and the type of pathology. And take-home message is, remember the anatomical peculiarities of hallux valgus in children. Conservative treatment is the first choice for younger children, though you can consider a growth modulation at this age if sufficient growth is remaining. Carry out a la carte surgery after maturity. Favor minimally invasive surgeries wherever possible. Fusions for neurological and syndromic deformities. And of course, you need to correct the concomitant associated deformities like pes planus, equinus, and genu valgum if present. Thank you.
Thank you. Now the house is open for the discussion on the deformity correction. Hitesh Shah, regarding the congenital malformation of the ankle and subtalar joint. Sir, is there any role of genetic therapy in the management of congenital malformation?
Associated with the tibial hemimelia, it is very common to have a P1T1X gene as well as the ZRS gene, but that is not common in therapeutic. That is only for diagnostic. So therapeutic, the gene will be on way. It's not, at present it is there, but it may be future.
Sir, have you ever tried a stem cell therapy in pediatric deformity?
I don't think so. It's a stem cell will have a role for the limb deficiency, because when there is a deficiency is already present on the medial half, there is anatomical structures are not there. I don't think so. Is there any role of the stem cell therapy for the limb deficiency at present?
Okay, thank you, sir.
So, Dhiren, you were talking about the compensatory deformity. So, if you have a supramalleolar deformity, but it's long-standing, you end up with a subtalar deformity. You mentioned it, but you did not tell us how you plan your correction in those cases. So,
So the question is about the compensation which is taking place. Yeah, fine. If it is there, then once we correct the supramalleolar portion, we have to take care of the portion below the ankle joint. Otherwise, like, we will not be able to correct the complete
so
deformity.
you would correct both, or you would correct less
Both.
on top? And
Both.
Okay.
Any more questions before me?
My question for Alex Bhalgas, with Dr. Ritesh Pandey, that whether you need, when you do multiple metatarsal osteotomy near base, then whether you need any fixation or just you leave it.
Normally, we don't fix the central metatarsals because they are low energy osteotomies, and it usually heals very well without any fixation. And it gives you space to move them when you are correcting the first metatarsal deformity. And we don't normally go for fixation of the central metatarsal. The first metatarsal we do fix.
Sir, one thing. Is there any role of a spacer in a spacer in Alex Walker? Yeah. Okay.
There's a toe spreader that you use.
So we don't have a talk from Dr. Sukalyan, and next we have a video session by Dhiren sir.
Fine. So, I have a colleague, Dr. Kamlesh Devmurari in Ahmedabad. Whenever he attends any conference, he attends the conference with only one aim, that how many new surgical procedures I am learning from that conference. And when we are together, at the end of the conference, he will say that, Dhiren bhai, now I learned 6 new technique which I am going to apply. So I always look at that. He's very smart, and whenever he attends a conference, he has only one aim, to learn a new surgical technique. So I am sure that many of you would also agree with his philosophy that we want to learn something new surgically which can help us to carry out the surgery. So to ask you the question, how many of you have done lateral column lengthening? Fine. So for remaining, I am sure that I will try to make this procedure very easy. For you, you will learn some new surgical tips from the same. Let me tell you, I have a video, but first of all, I would try to explain you the theoretical concept. And then if time permits in this session or later on, you can see the video. But I would try to make it simple and easy to understand why and how we need to do this procedure. So the indications are flat foot deformity with the short tendoachilles. That's the first indication, a common indication. And those who are treating cerebral palsy children, for them the planovalgus foot in cerebral palsy is the second indication. There is a slight difference in the surgical procedures in addition to that what we do, but the basic lateral column lengthening is same for both. Yesterday, Ritesh asked me the question, and the Sukalyan also asked me about what about the tibialis posterior plication. Yes, when we are dealing with cerebral palsy child, we have to add that procedure along with the lateral column lengthening. So let's take a cerebral palsy, planovalgus foot deformity. This is what the classical appearance is. What are the components? This is going to be a revision, but still I'm explaining it again so that we understand when it comes to surgical procedure. The component is hind foot valgus. We already saw that in a previous picture. There is a hind foot equinus, midfoot break, forefoot abduction, and the forefoot supination. This forefoot supination is a new thing for those who are not familiar with this, and I will explain that why it happens and why we need to take care of that component. So let's say that this is a hind foot valgus. Very clear, like when you look at the child from behind, the foot is in valgus. The hind foot equinus is very important. Like when we look at the lateral aspect, take a weight bearing x-ray and look at the x-ray, the talus is not horizontal, but it is slightly oblique. But when there is a short tendo Achilles, either flat foot or cerebral palsy, the hind foot is in equinus. So now talus is more vertically oriented than its oblique position. And there is a midfoot break as seen in this animation. So this is what the midfoot break is. So that's the third component. The fourth component is forefoot abduction. Again, we saw this yesterday. Now, lateral column lengthening and the additional procedures which we do will take care of all these components. So we see the foot as two columns, the medial column and a lateral column. On a medial column, we have 3 bones. On a lateral column, we have 2 metatarsal and cuboid. So medial column is long, the green one is long, the orange one is short. And this is how we correct. We cut the bone and then we correct it. Again, I am playing the animation. This is how we correct. It looks really well on the animation, and the same thing happens surgically also. So once we correct it, we put a bone graft in that. So now coming to the operative techniques. So these are the 2 incisions. One incision along the Langer's line. This is very good, but I prefer this incision which is along the peroneal tendon going towards the 5th metatarsal. We are crossing the Langer's line perpendicular to that. It is not well cosmetically, but fine. It's easy for me, so I use this approach. But you can use the one which is described previously. So once we expose, the first structure which we see are the peroneal tendons. Right? So we separate out both the peroneal tendons. Now we need to remember that we are lengthening the lateral column, so peroneal are going to become tight. And for that we need to lengthen them, because if we don't lengthen them, we will not be able to get the correction there. So for that we need to lengthen the peroneus brevis. We don't do anything to the peroneus longus. Look at the calcaneocuboid joint. It's not at all difficult. When we palpate with the periosteal elevator, we will be able to fill a gap, and that tells us about the calcaneocuboid joint. If you are not comfortable, use image intensification, and that will immediately guide you to that. Once we identify calcaneocuboid joint, actually we may not go or carry out dissection right up to there, but for those who are doing it for the first few times, please extend your incision by a centimeter or so and locate calcaneocuboid joint. Have a very proper understanding about the anatomy, so it makes things easy. Then we go 1.5 to 1.7 centimeter proximal to that calcaneocuboid joint. And we will be right into the sinus tarsi. It's easily identifiable area. You put your small lever, periosteal elevator or a lever into that area, and that will go very easily over there. If you want to excise the soft tissue from that area, you can excise, but it's not necessary to excise soft tissues from sinus tarsi. So yesterday also we saw this. Again, I would like to emphasize the point how our osteotomy travels. So this is the calcaneum. The lower part is anterior. the one which is on my side, left one is a lateral side. So the osteotomy goes, so there are three facets, the anterior facet, medial facet or a medial facet, and then posteriorly there is a large posterior facet. And osteotomy is intra-articular osteotomy between the anterior and medial facet. This is how our osteotomy goes. So this is what, like we have a periosteum elevator in the sinus tarsi, and then we look at the image intensification that our osteotomy is exactly at that point, and then we carry out a osteotomy like this. We can cut it with osteotome, we can use a saw also. It depends, like if you have a mini blade, you can use that. I use osteotome. And once we cut the osteotomy completely, we fill a giving way. So that is another important thing. Now, once you have cut the bone, don't go for distraction. We need to fix the calcaneocuboid joint, because if we don't fix it, there may be a subluxation of the calcaneocuboid joint take place when we are trying to distract the lateral column. So we need to fix it with a K-wire, which is passed percutaneously between the fourth and the fifth metatarsal. We just fill them and then use a K-wire and then we pass it. What I do at this point, I put a 1.5 centimeter osteotome in the osteotomy. And then I pass a wire. So when my K-wire touches the osteotome, I get a feeling that yes, I am exactly at that point, and that confirms that the K-wire is also in center. You can take help of IITV to locate, but this osteotome technique gives us so confidence that we are exactly at the right spot, or our K-wires are exactly at the right spot. We take out the osteotome. Now we have fixed the calcaneocuboid joint, so we are ready for distraction. And this is how it goes. Before distraction, we need to remember a few things that I will explain in a minute. Put a graft, and then we will going to complete the procedure. Extend the wire, and then we will pass the second wire. For distraction, there are various ways. Some people use two osteotome and then they try to open up. I have or some people use it, the lamina spreader, the small size lamina spreader. The problem with that is like it crushes the cancellous bone. Somehow our children's bone are not that strong enough, and when we apply this periosteum elevator, it crushes the bone. So instead of actually opening the osteotomy, it crushes the bone. So I have found this instrument, the one which is shown over here. There are two holes in that, and through that I pass the K-wire, one in the cuboid or in the distal end of the calcaneum, and other in the proximal part of the calcaneum. We use 2.5 millimeter thick wire, and then we bent it, and then we use this instrument. So with the help of K-wire, we will distract the osteotomy. At that point, if it's not opening, then probably something is left at the medial aspect. So we need to use a small osteotome and cut the medial border of the calcaneum completely. Otherwise, it opens really well. So that is one thing, that if it's not opening, ensure that you have cut the distal end, which is not easily visible. So what we can do is like we distract a bit, and then we use osteotome to break the medial border completely. So once we do that with the help of the instrument like this, I have forgotten the name of this instrument. It's some interments. Yes, exactly. So we use that, and this is in place, and that is showing that now.